and also in other peripheral vascular diseases like in the many disease like atherosclerosis, then Berger's disease, uh, and the like gangrene also. Well, it comes under CODA. The in first paper only it is coming. Okay. Then I mean that among the disease of snayu, mainly only tennis elbow I have included. Already I have took ganglion. Okay. So first we will go on to varicose vein. So what is varicose vein? Why we have to learn about? Because all mainly our patients, so many patients will come with varicose vein, and I think compared to allopathy management, we have better management. Okay, so it is a bread and butter surgical case, and with a less risk also, with a minimum OT setup, we can do that also. So, and we have to be able to identify the varicose vein, the particular venous system affected, and the level of incompetence. And chronic venous insufficiency is characterized by certain venous changes, which must be we have to identify. So, what are varicose vein? These are the dilated tortuous vein due to the mainly the etiology is due to the venous incompetence, often due to the valve dysfunction, and commonly affecting lower limb. So, as you know, it is a penalty man has to pay for his upright posture, because in other animals, four legs are there to support the whole body, but for men only we have to, the blood should be, the venous return should be against gravity, and that too it is by two legs only. So it is told in as it is a man's penalty for his upright posture. Coming to the definition, it is a dilated, tortuous, and elongated superficial vein with a reversal of the blood flow due to incompetence of valves. It is seen only in human beings due to the erect posture. And a varicose vein, it is the one where there is permanent loss of the valvular efficacy. As a result of continuous dilatation under pressure in a course of time, varicose vein becomes elongated, tortuous, pouched, thickened, inelastic, and friable structure. So almost incidence we can see 5% of general population having varicose vein. Mostly develops by 30 to 50 years of for all persons. Women mostly affected, mostly because of due to the pregnancy or the hormone related theories also there. So like that, a loss of valvular mechanism forces blood to flow abnormal pathway, particularly during the long standing and hanging the legs while sitting for long duration by venous and capillary pressure increases over a period of time, leading to chronic edema, repeated inflammation, and finally post-phlebitic syndrome, including stasis ulcer, which is difficult to manage and often disabling. So that varies, the means twisted. These are some of the history of the varicose vein. Then where we can see other varicose vein, we have mainly we are concentrating here about the lower limb varicose vein. The other areas it will come among the other disease, other areas like a disease of esophagus. In that esophageal varices, that is there we will get the gastroesophageal junction, the varicosity, that is called esophageal varices. Then varicosity of the hemorrhoidal veins or the superficial rectal veins are called piles or hemorrhoids. Then varicosity of the spermatic veins in the varicocele. I think already these topics, some of them are covered. So coming to the surgical anatomy of the veins and of the lower limb. Mainly, there is superficial venous system, deep venous system, and perforators connecting them, and valve are there. So long saphenous vein, short saphenous vein are the superficial veins, deep vein system, and the connection is called perforator, that is indirect perforating veins and direct perforating veins are there. So just go through the anatomy. Then what are deep veins? Main deep veins are posterior tibial and its tributaries, peroneal veins, anterior tibial veins, popliteal vein, and draining to the femoral vein. Then characteristic features of the deep vein. As we know, the muscle pumping only will make the blood flow upward. So we are having the valve to prevent the backflow of blood, venous blood. So in case of varicose vein, normal vein, you can see the valves will be there. So only upward flow will be there, and downward it will be prevented by the valve. But in case of varicose vein, the valve will be incompetent. So what happens? Backflow or the reflex of the venous blood will come, and there will be venous stasis. What are superficial veins? It lies in the subcutaneous fat between the skin and deep fascia. They are long saphenous or great saphenous and short saphenous vein. It is the longest vein, long saphenous vein. It is the longest vein of the body. It begins at the medial marginal veins of the foot. So only the symptom starts in the ankle region. Then ends in the femoral vein about 3 centimeter below the inguinal ligament, and above about 20 to 30 valves are there. These are the tributaries. Just go through that. Superficial epigastric vein, superficial circumflex iliac vein, then external pudendal vein, deep external pudendal vein. So why they are important? Because of the connection between these two veins, varicosity may spread from one to another. At time of ligature, all tributaries and other veins should be carefully ligated, or else varicosity may develop in other veins. So ankle flare will be seen. That also these are in these where the veins, smaller veins are there it is called ankle flare. Then the connections, we can see some connection with between the superficial and deep vein, that mainly near the ankle, then in knee and the thigh. So they are called perforators. Then short saphenous begins at the lateral malleolus as a continuation of lateral marginal vein of the foot. So just go through that. Then these are the connecting communications between superficial and deep veins are called perforating veins. Then coming to the central perforator, lateral perforators, like that it is there. Next, coming these are the just pictures I have shared. Then physiology. The main actions, these two main actions ensure the venous return. The presence of anti-reflex valve, blood to move in one direction only, and a pump mechanism which activates and maintains the blood flow throughout the vein. So, what is a pump mechanism? It is a stimulation of the venous nervous system of foot and the calf muscle. The muscles only, the pumping, that pressure is 200 mmHg. Then heart pump and negative pressure phenomena also during breathing, increase in the abdominal pressure at rest. All these accompany the pumping mechanism. Then mainly the gravitational factors, histology of the veins, hemodynamics, all these are important in the valvular mechanism. Now coming to varicose vein. What is the etiology? We can divide it as a primary factors and secondary factors. Primary factors, but it is not congenital, it is primary, but it is mainly no associated symptoms or disease are there. Just it occurs in second and third decade, and secondary factors mainly because of any other disease. Okay, so primary, secondary, and even congenitally also it will happen. So primary varicose vein mainly if there will be a defect in the saphenofemoral valve. So mostly it occurs as an occupational influence and congenital due to congenital incompetence of the valve also, like valvular syndrome, Klippel Trinori syndrome, like that. Then some genes also as isolated in severe case of hereditary, like FOXC2 gene also isolated. Then secondary varicose vein, mainly secondary to any other disease or any other physiological changes like pregnancy. Then other tumor like ovarian cyst or some like uterine or any lower abdominal pathologies. Now, obstruction of the venous return, multiple pregnancies, straining during constipation. So all the like chronic cough, all this will be having some strain on the veins. Okay, so which is causing obstruction, and like DVT, deep vein thrombosis and obstruction, it can also damage. Then acquired damage of the calf muscles, then altered hormonal climate in the body like progesterone and relaxin. All these will be having effect. Then some acquired arteriovenous fistula also. And what is congenital varicose vein? Mostly developed sometimes below 20 years. That we can consider as a congenital variety, mainly due to arteriovenous fistula or in cavernous hemangioma. In that case, congenitally varicose vein can occur. So risk factors, as I told, hormonal, like a high estrogen state in female, then lifestyle because of the prolonged standing or sitting, then smoking, And then this mainly result in venous hypertension or venous endothelial injury. Then in case of acquired obesity, pregnancy, deep vein thrombosis, or in the older age. So mainly in obesity, what happens? Venous hypertension will be there. Pregnancy, high estrogen state will cause venous hypertension. Then deep vein thrombosis, deep vein obstruction, and valvular incompetency. Age also valvular incompetency. The muscles will lose the strength, so that they will be not able to hold the valve of the veins. Then inherited, like a family history, tall height, congenital syndromes, all can have a these can be considered as a predisposing factors. Same only I have repeated. Then pathology. So first of all, there will be destruction of the valve, and the blood becomes stagnated. The play of high, because of the high pressure, there will be stagnation or venous stasis will occur. More important than the elongation is the widening of the veins, which cause the valve cusp to separate. So when the patient stands, the gravity, the blood is pulled backward by gravity. So that is lost. Then we can see that thrombosis and valvular deformities are responsible for the fibrin. Some theories are developed, like fibrin cup theory or white cell trapping theory. So what happens because of the in fibrin cup theory, it is told incompetence of the venous valves are the resulting in the stasis of the blood and resulting in chronic ampullary venous hypertension. Then defective microcirculation. What happens? As you all know, the RBC in within 120 days, it have to return to the liver or spleen and for the purification or a destruction. Okay, so but it is not reaching back. What happens in that different planes? That tissue plane itself, the lysis of the RBC happens, and that results in a release of a hemosiderin, and that hemosiderin is a result resulting in the pigmentation or hyperpigmentation of the skin. Then it is a, actually this hemosiderin is an irritant. So what happens when this irritant is coming accumulating there, then we will start having developing the itching. Then it result in dermatitis, and then capillary endothelial damage, and because of the prevention of diffusion and discharge of nutrients, there will be severe anoxia and resulting in chronic venous ulcer. So that is the fibrin cup theory. Then white cell trapping theory. Inappropriate activation of the trapped leukocytes release the proteolytic enzymes, which causes cell destruction and ulceration. So that is a white cell. So both red cells and white cells have action in this pathology. Then coming to the classification. So as you all know, we can identify the route where the veins are there. So long or great saphenous vein varicosity, short saphenous. So long saphenous, it runs along the medial course of the thigh, and short saphenous in the posterior or lateral sides. So like that we can consider. Then in some typical case, we can see that perforators incompetence also we can identify. In classification 2, in the starting stage, we can see as some cases thread veins or dermal flares or telangiectasis. The terms are used like to explain the spider veins, like a thin veins will be seen, 0.5 to 1 mm inside. Then reticular varices, like 1 to 3 mm in size, located in the subcutaneous or subdermal region. Then coming to the bigger varicose veins located in the subcutaneous tissue, and mostly the subvenous compartment more than 3 mm in diameter. Otherwise, we can see the combination of any of the above. Then some of the classification, like CEAP classification according to the clinical sign, or etiological classification, like congenital, primary, secondary, or no venous etiology. Then anatomy, A for anatomical distribution, that is superficial, D for perforator, or we can identify. Then P for pathophysiological dysfunction, whether there is obstruction or reflex or both, like that. So that is one classification. And then grading according to 0 to 6 is told. So in the first case, sorry, in the first case, maybe no visible signs of a varicose veins are not seen, but the symptoms like skin changes and all are seen. Then telangiectasis, I already told, spider veins will be there. Second degree, it is great, it is varicose veins are visible. Then third, again along with varicose vein, edema without skin changes. Then fourth, the skin changes due to venous disease like pigmentation, eczema, and lipodermatosclerosis. So like that, 4A, 4B are given where there is pigmentation, it is called 4A, 4B is lipodermatosis. Then five, skin changes as above with the healed ulceration. Then six is the with active ulceration. So these are the according to the clinical signs. Then anatomical distribution, like according to the superficial system or deep system or perforator system or like that, it is classified, not having that important. These are some of the pictures of the varicose vein we can see. In the first picture you can see the enlarged veins. Then in the third pic, you can see the fourth pic, actually the edema, how the edema will be. Then last, like skin rashes and all, skin eczema and all, that dermatitis condition like that. So coming to the symptoms, so most of the patient comes with a cosmetic difficulty. They will tell only the veins are seen. It seems ugly to look. Okay, so is it asymptomatic? Can be asymptomatic till one level. Okay, so only the dilated tortuous vein is that which is asymptomatic but cosmetic. Then dragging pain or aching pain, the complaints in the evening while long standing or long hanging of the legs, like that dragging pain will be there and it will be relieved by rest. Then heaviness, tiredness in the legs. The nighttime cramps, usually late nights typical. Then as the venous return is not occurring, then edema of the foot, itching, discoloration, or ulceration. So that these are the symptoms. Then at signs, we have so many tests are there. I'll go through that later. So some of the test names are Fagan's test, then superficial thrombophlebitis like resulting in ankle flare, dermal flare, thread-like veins. All these are the signs. Then reticular veins in the subcutaneous vein. Safina where it's a large varicosity in the groin, one of the complications also. Then talipes, how the patients will be walking like a hose. So in the tiptoes, that is talipes equinovarus, how the patient will be walking because to avoid the pain of the calf muscle. Okay. Then champagne bottle side, it is inverted beer bottle look, mainly because of the contraction of the ankle skin and the subcutaneous tissue with the prominent edematous calf. You can see why the name came. Champagne bottle sign. Then coming to the aches and pains, mainly because of the capillary pressure and reduced capillary permeability, only the aches and pain happens. Then ankle edema in the ankle region because of the pooling of the venous blood, and the lymphatic drainage is also blocked. Then varicose eczema or gravitational or stasis eczema. Coming to the physical examination, so as you all know, first we have the inspection. So in inspection we have to see the patient, examine the patient while standing, and mainly examine around the medial malleolus. So venous ulcers mostly occurs in around the medial malleolus, great saphenous veins where it is emerging. Then some happening is that varicose veins distribution, whether it is long saphenous vein or short saphenous vein. Then whether there is a venous ulcer or eczema is there, where the venous stars or the flare, how it will be appearing. Then lipodermatosclerosis, the change in the skin, or like a hardening of that area, developing into a lipodermat, that is called lipodermatosclerosis, sclerotic changes in the skin. Then atrophy blanche, where the discoloration we can see. Then pitting edema. So then scars. So these are the and in inspection we have to see whether ulcer or edema is there. Atrophy blanche is there, that is active or healed ulcer with white patches. It is called atrophy blanche. Then stars or spider veins are called venous stars. Then coming to the pitting edema, when we are palpating on deep palpation, pitting edema is seen. Coming to the test, Brody Tendlenberg test, Perth test, modified Perth test, then Schwartz test, Pratt's test, Fagan's test, Morrissey's cuff impulse test, three multiple tourniquet test or Ochsner test just below the saphenofemoral junction or above the knee level, another below the knee level, then where the three multiple tourniquets are kept. So in that first palpation only, there is all this test. We have to palpate the dilated veins. Then body Trendelenburg test. It is to determine the incompetency of the saphenofemoral valve. Mainly two methods. First, we have to see in the supine position, then proximal milking, then pressure on saphenofemoral junction by thumping of the thumb by using thumb of the clinician, and without releasing the pressure we have to ask the patient to stand up. Then in first method pressure is released, and while standing up the pressure is released and the veins will quickly fill by a column. It indicates incompetency of saphenofemoral valve. It is called positive Trendelenburg test. You understand, I think, when we are the patient either in supine position or in the left lateral like Trendelenburg position, we have to make the patient lift the legs so that all the veins are emptied. Then pressure is applied on the saphenofemoral junction, and the ask the patient to stand up immediately. Then we are releasing the thumb in the first method. So what happens if the saphenofemoral valve is not competent, there will be backflow, and the blood will start from the filling from starting from the up. Okay, it is called positive Trendelenburg test. And in second method, the pressure is not released and but maintained for 1 minute. So gradual filling of the veins indicate incompetence of the communicating veins. So that is first. That is in the first case we are in the competency of the saphenofemoral vein valve is test, and here communicating vein incompetence is understood in second method. So this is called positive Trendelenburg test. Next, coming to the tourniquet. We have to tourniquet at the different levels around the thigh after emptying the vessels, and the patient is made to stand. If veins above the tourniquet is filled and below remains empty, it indicates the presence of incompetent veins, communicating veins above the tourniquet. So like that, it is a tourniquet test. Then Pratt test. It is to know the leg perforators. Elastic band from toe to groin is used or tied, then tourniquet at the groin, then remove the elastic tourniquet, reapply from groin to toe at a position of incompetent perforator. A blowout will be seen. So that is the Pratt test to identify the lead perforator. Then modified Perch test to know the deep vein or are competent or not. Tourniquet is tied at the upper part of the thigh. Patient is made to walk quickly with a tourniquet. If the communicating and deep veins are normal, the varicose vein will shrink, because what happens when we are making the patient to walk, the muscles are acting. So what happens if as the tourniquet is tied in the thigh, there would not be any venous return. So that this connection, why there is connection with the superficial and deep vein, the it is to help the shunting of the blood. So if the there is any block or we are tying at the superficial vein, it should go to the deep vein and drain it. So if the patient is normal, the varicose vein will shrink. Okay, so that is the modified Perch test. So it is to mainly used to see whether the deep veins are normal or there is no deep vein thrombosis is not there. Then Schwartz test. If tap is made on long saphenous vein in lower part of the leg, an impulse is felt at the saphenous opening with the other hand. So that is the Schwartz test. Then Morris's test or cuff impulse test. Veins are emptied. The patient is asked to cuff forcibly. If saphenofemoral valve is incompetent, an expansile impulse is felt in the long saphenous vein. And auscultation, a bruit may also be heard. Then next, coming to the Fagan's method to indicate the site of perforator. In standing position at the site of excessive bulge is marked by a skin pencil. Now in supine position, the affected limb is elevated and the heel is supported. The examiner palpates along the vein, and a gap or a small pit is felt. In the deep fascia is marked as X, and it is the site of perforator. It must be compared with the previous mark. So in standing position and supine position, we have to see where there is excessive bulge and excess dip will be there in the supine position. That is the mainly where there is a perforator. And other examination per abdominal or per rectal or per vaginal to rule out the cause or the secondary reasons of the varicose vein. Then these are some of the features. Then others are like a Horman's test, Moses test, and that all we will come across in the DVT. Nerve sign, all these are mainly in the DVT. Next, other percussion, auscultation also I have explained. Then regional lymph nodes in case of venous ulcer and there is infection in that and all, lymph nodes will be obviously enlarged. Then we have to test the corresponding other limb also. So, test for saphenofemoral incompetence, perforator incompetence, and deep vein incompetence or deep vein thrombosis. So, that is, we have to test all these signs. Then, coming to other examination, abdominal examination, and all to rule out the secondary causes. Next, investigation. The main important is the Doppler. So we will get the venous Doppler. If arterial diseases are not suspected, venous Doppler is given. So in that we can see the backflow of the blood in or the venous blood. We can see in the Doppler or duplex ultrasound imaging, then venography, vericography. All are using like some dye is injected and like that is there. Then some cinephlebography. All these are the some of the where we can correctly identify where the block is. I think no need in detail for UG level, plethysmography and all. Just go through that. I will share the notes. Then if it recognizes the normal flow or distorted flow or absence of flow, then femoral vein transmits the venous hum. So the calf region transmits the venous roar due to increased blood flow normally. And if DVT is not and is there, then no roar will be there. So that is the to rule out. Mainly Doppler will suggest to rule out DVT so that we can treat only the venous varicose vein. Next, coming to the complications, thrombophlebitis, that is the inflammation of the superficial vein. Phleb, the term meaning is vein. Angio means artery and phleb means vein. So here, inflammation of the superficial vein is called thrombophlebitis, and there will be pigmentation, discoloration of that full ankle region, then the lower limb, then eczema or chronic infective dermatitis, and venous ulceration that is called gravitational ulcer. It is occurs secondary to the vein, varicose vein. Then hemorrhage, sudden hemorrhage can occur. Only just a raising of the leg is enough for stopping that from rupture of the varicosity due to any minor trauma. And calcification can be seen in the walls of the vein. Then ankle flare, lipodermatosclerosis, periostesis, equinus deformity. All this are the some of the pictures. Hyperpigmentation, varicose vein, how it is appearing, ulceration, lipodermatosclerosis, ankle flare, and static dermatitis. Next, coming to the management, palliative care, the compression sclerotherapy, empty vein injection technique with a sodium tetradicyl sulfate is also done. Then some other operative procedures. So as a conservative treatment, the Basgard method is explained. That is 4ME, that mnemonic is that like 4ME ABCD, 4 layered bandage, change 1 time per week. M for massage, L for elevation of the foot, then antibiotics to prevent any infection or of the ulceration, then bandage, elastic wrap bandage from below upward, or stockings to the limb pressure gradient 30 to 40 mmHg. Then cleansing of the ulcer, dressing with use of then exercise. Coming if the venous bleeding occurs, controlled by just elevation and a pressure bandage. Then eczema and dermatitis if there occurs due to the extravasation of and breakage of the RBC in the lower limb, versus itching and varicose ulcer treated by zinc oxide cream. Then thrombophlebitis, it is treated by bed rest, elevation, crepe bandage, antibiotic, and anti-inflammatory drugs. Then coming to the compression sclerotherapy or empty vein injection technique, injecting a sclerosant agent, that is sodium tetradecyl sulfate 3% into the dilation, which acts to by damaging the intima of the veins to cause a thrombosis and later endosclerosis. Next, ultrasound guided sclerotherapy also now it is available. Phlebectomy. Phlebectomy is a used to remove the smaller surface vein that lies under the skin. Small cut about 5 mm long is made on the leg and affected veins are pulled out by using hooks. Operative procedures indication mainly positive Trendelenburg test and saphenofemoral incompetence. The ligation, the saphenofemoral incompetence, saphenopopliteal incompetence, in that case, ligation is done. Ligation and stripping is done under general anesthesia. It needs to cut off 5 mm long um, incisions at a groin and ankle or knee. Then also cryosurgery is available. A cryoprobe is passed down the long saphenous vein following saphenofemoral ligation. The probe is cooled with a nitrous oxide or a carbon dioxide to a temperature of 85 degree minus 85 degree. The vein freezes to the probe and stripped after 5 seconds of freezing and retrogradely. So, and the only point of this technique is to avoid a distal incision to remove the stripper. Then endovenous thermal ablation technique is there. Then medical treatment, although successful reports are of medical treatment are there, but not yet published. Like so many drugs are have been tried and a result is published. So first of all, we have to do the lifestyle modification like weight loss, exercise, elevation, avoid prolonged standing or sitting, then any smoking, stoppage of smoking. So mainly for all type of varicose vein. Compression therapy mainly in minor varicosities and symptoms which are moderate to severe. Then local ablation therapy, sclerotherapy, thermoregulation are cutaneous laser inspired telangiectasis reticular veins. Surgery in case of large branch or residual post-ablation varicosities, saphenous varicosity, and endothelial ablation or using radio frequency or laser can be used in the saphenous varicosity. So these are the management, and this is under general anesthesia, spinal anesthesia, how the saphenofemoral incompetence is managed by strip ligation. Okay, so ligated that you can see the stripper, ligated venous branch you can see, and the vein being removed. The ligated venous branch you can see, and in each level the ligation is done. So just 5 below 5 centimeters medially to the femoral artery pulsation is done. Then ligation and stripping, mainly in the great saphenous vein, it is done, ligation and stripping. So even that also, the complications are more. There only we have the more role in the Siraveda and the other all Upanaha karma or Basti karma, all are indicated in Siraj Grandi. I think already Siraj Grandi we have last class, it was my class was about Siraj Grandi. So these all symptoms we can get in our Ayurveda management. But in allopathy, we get more of the complications also, like bruising, discomfort, pain, tingling sensation, numbness, and even finally, as a complication, DVT also. So, sclerosin, like ethanolamine oleate also is used as then STD. Then even venous ulcers, it is mainly found as a complication. It is the most commonest complication is the venous ulcer found in the medial gaiter area. That is a medial, near the medial aspect, lower third of the medial aspect of the leg, immediately above the medial malleolus. Shape and size irregular, variable size. Maybe the base ulcer, how you I think already vrana is taken. So in that dushta vrana concept is applied, can be applied here. The base may be covered with a yellow slab, while healing there will be pink granular tissue formation. Surrounding tissue may be the signs of chronic insufficiency. It can be seen like discoloration, pigmentation, and all. inspection, we can see the lipodermatosclerosis, that is a scarring of the skin and fat, and it may be in a number of years, but patient may not notice also. Then venous pooling, chronic venous hypertension we can be seen. Then RBC is forced into the surrounding tissue, and hemoglobin or the RBC breakdown to form the hemosiderin. In chronic cases, it leads to fibrin deposition, and the skin will be thickened and shiny, and there will be inverted champagne bottle shape as seen. So I think all these points already I have discussed. Now moving on to the next topic, that is deep vein thrombosis. Is it visible? I think it is not able to. Just a minute. So our next topic is deep vein thrombosis. Mainly both venous thrombosis comes under the disease of veins or sera. So in that, first deep vein thrombosis. In that also I am explaining superficial also, but mainly deep vein thrombosis comes to our practice mostly. The anatomy of the deep veins in the lower limb. Yeah, that the tibial, popliteal, femoral veins, that has the veins with drain the blood into the iliac vein and then to the inferior vena cava. So musculovenous pump and peripheral heart pumping veins are also there. You can see the picture where the posterior tibial and peroneal, anterior tibial, how they are draining the ankle region and the lower leg region, and reaching to the inferior vena cava. Just go through that. Then already I told the anti-reflex valve and pump mechanism while explaining varicose vein. So what is the definition of deep vein thrombosis? Deep vein thrombosis, or the deep venous thrombosis, or DVT, or phlebothrombosis. These all are the synonymous used. Then it is a formation of a thrombus or a clot, blood clot in a deep vein. And the main complication is the pulmonary embolism. So once this clot is removed or lodged from that region because of any other mechanical reason, like if you are like massaging thoroughly or like that, anything is there, so only we are doing the Doppler to rule out this case. Otherwise, if any small thrombus is inside the deep vein, maybe during our abhinka and nadi sweta and all, it may get dislodged and can reach even to the pulmonary artery. Okay, so that can result in the pulmonary embolism. It is a major dreadful complication. So it is a condition that occurs when an artery in our your lung becomes blocked. So that is about the deep vein thrombosis. And mainly Virchow, the Rudolf Virchow has explained the triad, okay, which are the triad venous stasis. There will be what are resulting in this thrombus, that is explained. Mainly some vein wall injury will be there, which as a etiology, vein wall injury. And obviously for the clot to form, there should be any hypercoagulability disease, which is increasing the coagulation of the blood and resulting in any other causes, also resulting in venous stasis. These all result in the thrombosis. Next, so we can see the remember is as a thrombosis, the term itself, T for trauma. So I used to remember one case explained by my surgeon, like one day after the procedure, after anorectal disease also, while we are shifting the patient, sometimes we may just hit the leg. That person will be anesthetized. Okay, so while shifting, maybe in the lithotomy table we have that stand for the footrest. Okay, so that the patient was hit on that with a by the leg or calf region, and a clot formed. As the patient was anesthetized, he was unaware of that, and next after 2 3 days he developed a pulmonary embolism and died. So that is actually the person, the fault from the person who are shifting the patient. So even that also we have to take care that patient is not having any surgical traumas also. Then even by bystanders also, like that mistakes we can have. Okay, so that can result in the deep vein thrombosis. Then hormonal, then road traffic accidents or operations like a cholecystectomy. Then due to any other clot formation, we are doing the procedure in anesthesia complications also, we will get all the thrombus formation and all. Then as a result of any malignancy or any blood disorders like polycythemia, then obesity, old age, orthopedic surgery, serious illness, immobilization. So most of the surgeries we need immobilization. So the immobilization and can result in the clot of the blood. So these all results in the thrombus formation. And we can see the picture how the thrombus is causing the obstruction. Primary platelet thrombus will occur. Then like that coralline thrombus, layer by layer it is going, occluding thrombus, and then last the clot, it is fully blocking or obstruction is resulted. Then clinical feature, pain in the leg. So this that varicose vein we don't have much pain, or sometimes only the pain will be there. Here pain in the veins, then tenderness in the calf, one of the most important sign. Then even gentle pressure on the calf itself will be having tenderness, severe tenderness. Then swelling of the legs, the redness of the legs, increased warmth of the leg, then bluish discoloration, skin discoloration. Sometimes whitish also it can occur. Painful white inflammation or milk or white inflammation of the legs can occur. Mainly it result in the due to the DVT of the femoral veins. So that is called phlegmasia alba dolens. And phlegmasia cerulea dolens is a painful blue inflammation. It's called blue leg, mainly in the resulting the because of the extensive thrombus of the major and collateral veins. Next, coming to the diagnosis. Firstly, we have to do the clinical examinations and also the investigations. Mainly examination like Homan sign. Homan sign is like we have to like doing the SLR, straight leg rise, like that. We have to ask the patient to lift the leg, and then we have to actively dorsiflex the foot. That at that time, severe pain, cramping pain will be there in the position of the thrombus. Okay, so that is mainly in the calf region. So that is called Homan sign. Moses line sign is the main gently. We are lateral pressure we are applying on the calf muscle itself will be having pain. Then all these other signs also there. I will share the notes. Then coming to the investigation, venous Doppler, duplex ultrasonography, venography, MRI, blood clot. Differential diagnosis, some case of ruptured Baker's cyst, then ruptured plantaris tendon, calf muscle hematoma, cellulitis leg, superficial thrombophlebitis. All these can be considered as a differential diagnosis. So what is the superficial venous thrombosis? It is the blood clot in the superficial vein. Deep vein, if it is in the deep vein, it is deep vein thrombosis. If it is in the superficial vein, it is called superficial vein thrombosis. So it is called thrombophlebitis. Then varicose vein intravenous. I think most of the patient complained about thrombophlebitis even in the while having IV cannula for longer, like after cesarean session, like that. The patient, if the patient is not comfortable with the IV line cannula, so in that IV injection also can result in a clot formation and severe resulting in severe pain in that region. So that we can consider as a superficial venous thrombosis. And due to immobilization, hypocoagulable stage, all this can result. Then mostly sometimes varicose vein also is associated or some non-associated also. Then by pathophysiology, it can be primary or secondary. Then even septic thrombophlebitis is due to infections also. Then there will be pain, warmth, redness, and tenderness. Mainly use of compression, physical activity, medications like anticoagulants, NSAIDs, antibiotics, corticosteroids. Some local application also is available. Then like thrombophleb like ointments also available. If it is bigger and not relieving by medications, we have to go for ligation or stripping or thrombectomy. So you can see the thrombophlebitis, how it will be. Then deep vein thrombosis, the femoral vein and the blood flow where inside it will be. The area of inflammation can be like that. Treatment, rest, elevation of the limb, bandaging, anticoagulant, heparin. All these are the anticoagulants, warfarin and heparin only you remember. Then venous thrombophlebectomy, IVC filters in case of inferior vena cava filters. Then in acute cases like Balma operations, Mehes knees operations are also available. So this is a Palma operation for iliofemoral block using the opposite saphenofemoral vein or femoral vein, saphenous vein, opposite saphenous vein, femoral vein is connected to the other femoral vein. So like that it is done. But this is also having complications like pulmonary embolism, venous gangrene, chronic venous insufficiency, recurrent DVT, post thrombotic syndrome. And prevention, we have to care the patient for proper positioning, pressure bandage, lose weight if it is due to obesity, then stay active, regular exercise, and avoid smoking. So that is about DVT. Just a minute. And next, coming to the other peripheral vascular diseases. So in that, so these mainly these two comes under, and one more small topic is the hemangioma. I think that is not that much important for you. I'll share you in the notes. So next, coming to the diseases of the arteries. So these two were the disease of the veins. Now in that mainly arterial disease. So both can be considered as peripheral vascular disease. So venous disease I have explained separately. Now coming to the arterial disease, atherosclerosis obliterans, thromboangiitis obliterans, Raynaud's phenomenon, acute arterial embolism, cervical trip. All this comes under peripheral vascular disease. In that, first one is Berger's disease. So what is Berger's disease or TAO? The thromboangiitis obliterans. What do you mean by that? Thrombus. There is a thrombus inside the angias. Angia means what? Artery. So there is inflammation of the artery and thrombus inside that, resulting in the obliteration of the blood flow. So it is an inflammatory occlusive vascular disease involving small and medium sized arteries and veins, mainly arteries, okay, and in the distal and upper and lower extremities. Increased prevalence with the cigarette smokers of below 40 years. Coming to the etiologic factor, it is not specific, but a hormonal influence, genetic factor, autoimmune reactivity, or smoking is also can be considered as etiology. Coming to the pathology, there will be damage of the artery and resulting in the inflammation of the arteries and invading of the polymorphonuclear leukocytes, formation of the thrombus composed of platelet and the fibrin, thinning of the blood vessel and resulting in the recanalization and the perivascular fibrosis. So that is about the pathology. And coming to the clinical features, there will be first and foremost symptom is the intermittent claudication or the claudication of the affected limb, and then Raynaud's phenomenon, migrating superficial vein thrombophlebitis. First is the intermittent claudication. So what do you mean by claude? Claude means I limp. Because of the pain, the patient will be limping. The way the patient is walking is like a limping walk. So it is a claudication. Claudication means mainly cramp. Because of why they are limping, because of the muscular pain. So when the pain is when the patient will complain like when the pain starts on walking, okay, the patient will tell just a few minutes I'm walking, I'm getting the pain. But once we start walking and continuing the walking, the pain will disappear. Why? Because some substances like anaerobic respiration is happening inside the muscles, and the patient having the that substance is called P substance. That substance, what happens, it is accumulated on walking, but on further walking, continuing walking, the what happens, because of the pumping nature of the muscles, the P substance will be washed away by the blood. So that in the grade 1 Boyd's classification, grade 1, if the pain on the starting of the walking, there will be pain that disappears when the pain continues and the patient continues to walk. In the second grade, the pain continues and the patient can still walk, but it will be still painful because that much it has increased in the grading and resulted in the whole of the P substance cannot be removed by the action of the muscle. So next third stage, what happens? The patient have to take rest. Then only it will be relieved. So that is condition in grade 3. Then coming to the fourth degree or the final stage is the rest pain. It is called the cry of the dying nerve. Okay, cry of the dying nerve. This pain is due to the ischemic changes in the somatic nerve. Pain is worse at night and aggravation will be on elevated. So this is a typical sign where we can find the difference between arterial and venous ulcers or venous any diseases. Aggravation on elevation of the leg above the heart is seen in arteries, but if we are elevating the leg in case of venous disease, it will help the drainage, so the pain will be reduced. So here aggravation on elevation of the leg above the heart will be elevation aggravated, the pain will be aggravated and relieved by hanging the leg below the level of the heart. Later, severe digital ischemia causes tropic nail changes, painful ulceration and gangrene. Next, coming to the physical examination, inspection, no physical finding till gangrene occurs. Signs of chronic ischemia, like loose hair from the digits, atrophy of the skin, brittle nails, ulceration, or gangrene. Sorry for the mistake in the spelling. That is gangrene, GRENE. Then initial distal part later extends to the proximal part. Next, coming to the palpation. Palpation, absence of the pulses. As you know, we can identify the arterial and venous disease by the pulsation. How the pulse will be arterial disease, obviously, there will be either feeble or absence of pulse. In venous disease, the pulse won't be affected. So you can see one of the picture where the gangrene has darted. Investigation, arteriography. Arteriographic appearance of this is smooth and normal appearance of the larger arteries in combination with extensive occlusion of the smaller arteries along with the extensive arterial circulation. Treatment, conservative. Uh, we have to stop the smoking and tobacco. Abstinence should be there. Then vasodilative drugs like phenylbutazone or steroids should be given. Treatment, surgical treatment like sympathectomy, microvascular transplantation, amputation, when gangrene occurs. Next, coming to the Raynaud's syndrome. So, what is the definition of? So, first TAO or the Berger's disease is over. Next, coming to the Raynaud's syndrome. So, what is the Raynaud's syndrome? A Raynaud's syndrome is a condition characterized by episodic attacks of vasospasm that causes closure of the small arteries and arterioles of the distal part of the extremities in response to physical or emotional stimuli. So mainly it occurs in the cold countries because the artery it mainly occurs in the capillaries, small arteries, arterioles. So the blood is not reaching the tip or the distal end. Okay, so classically mainly three we can attack is divided as three phases: intense pallor, then cyanosis, rubor or redness. So warming for 15 to 45 minutes is required for full recovery. Finger and hands are most frequently involved. Coming to the classification: primary Raynaud's phenomenon or Raynaud's disease, then secondary Raynaud's phenomenon or Raynaud's syndrome. Raynaud's disease is also called primary Raynaud's phenomenon, and it is a primary disease where etiology is still unknown. Mainly, in case of secondary, mostly some other serious disease like immunological and connective issues, disorders like scleroderma, SLE, rheumatoid arthritis, all can be seen. Then other obstructive arterial disease like arteriosclerosis, like plaque formation in the arteries, then Berger's disease or thoracic outlet syndrome. All this can be there. Then environmental conditions like vibration injury, cold injury, direct arterial trauma, then drugs like cytotoxic drugs, birth control pills, excess use, all this can result in then neurological disorder, endocrine disorder. So, firstly, there will be vasoconstriction of the small arteries and pallor of the affected part, resulting in the cyanosis and hyperemia, leading to redness of the affected part. Cause of vasoconstriction is actually unknown. Then, majority of the patient is mostly precipitated by vasoconstriction is precipitated by cold exposure or external emotional stimuli also. Then mainly it is divided into stages. Stage of local syncope. On exposure to the cold, vasoconstriction of digital arterioles lead to decreased blood flow leading to the pallor. It starts at the tip of the fingers and gradually spread to the base. That is the local syncope. Then local asphyxia. There will be deoxygenated blood in the capillaries and resulting in the cyanosis, and the patient's finger will become cold and numb. Then stage of recovery. When spasm subsides, blood flow into arterioles and the fingers become red. So when the spasm is subsiding, the blood flows suddenly into the arterioles. So what happens? The finger becomes red and swollen, but it will produce severe pain and burning sensation due to tissue tension. That is a stage of recovery. You can see how the blanching or the white color you can see, and the tip how suddenly when it is coming back, resulting in gangrene formation. Physical examination, inspection, no physical finding detected. The starting stage and all palpation, we can feel the fingers and the hand will be feel cold. In chronic stages, like there will be finger wasting continuously. It is coming and going like in cold countries and all. And then the patient's finger become wasting. Will we can see, and it will be thin and pointed, leading to necrosis and ulceration. Investigation arteriography, we can see till how the arteries are being filled with the blood. Then blood investigation, ESR will be obviously raised. Then RA factor also sometimes in mainly to rule out rheumatoid arthritis. Then treatment, moving to a warmer climate. Then tobacco should be avoided. Vasodilator drug should be used. Then operation cervicodorsal sympathectomy. Then coming to the arteriosclerosis obliterans. So arteriosclerosis obliterans is a occlusive arterial disease most prominently affecting the abdominal aorta and the small and medium-sized arteries of the lower extremity, which may lead to absent dorsalis pedis, posterior tibial and popliteal artery pulses. So mainly it is seen in diabetic mellitus patient, hyperlipidemia, cigarette smokers. So mainly I told primary sites are abdominal aorta and iliac arteries, then femoral and popliteal artery, tibial and peroneal arteries. Atherosclerotic lesion occurs preferentially at the arterial branch points, site of increased turbulence, intimal injury. Coming to the pathology, so here the damage to the artery is resulting in the inflammatory response and accumulation of macrophages, formation of atherosclerotic plaques with the calcium deposition, thinning of lumen of the blood vessels, and resulting in the occlusion of arteries. You can see the how the normal arterial artery is lined. Then damaged artery, single damage, it can result in plaque formation, accumulation of the fat deposit and muscle cells, resulting in the narrowing of the lumen. Clinical feature here also due to lack of blood supply, then intermittent claudication occurs. Mainly it occurs during exercise and relieved by rest. Site distal to the location of the occlusive lesion, but a hip or a thigh discomfort, mainly in the aortoiliac disease, and calf claudication in femoropopliteal disease. Clinical physical examination, we can see the muscle atrophy as the blood supply is less. In chronic disease, hair loss, thickened nails, smooth, shiny skin, reduced skin temperature, and pallor, it can be seen. Decreased or absent pulses, distal to obstruction, the elevation of the legs or repeated flexing may produce pallor to the soles and feet, presence of bruises over the narrow artery. Then investigation, history and physical examination, duplex ultrasonography, mainly that is venous and artery together, duplex ultrasonography, and arteriography, arterial pressure recording. Coming to the treatment, supportive measures include more care to the feet and should be clean and dry, lifestyle modification to control diabetes and hyperlipidemia, then revascularization include angiography, stent placement, etc., and operative grafting. Next, coming to the next disease, acute arterial occlusion. It is a sudden occlusion of the artery due to emboli or trauma, leading to sudden cessation of the blood flow to the extremities, mainly because of either can be due to emboli or a thrombus in situ. Types of embolization: cardio-arterial embolization. Emboli in the lower extremity originate in the heart. Then then it causes like arterial fibrillation, mitral stenosis, MI, etc. Then arterial embolization, emboli originating from an atherosclerotic plaque. Say, site mainly in the emboli of the lower extremity, usually lodges at a bifurcation of a larger artery where the diameter decreases. So mainly in the bifurcation of the common femoral artery or common or popliteal artery. Then affects immediate onset of ischemia of the tissue supplied by involved artery. Then ischemia to peripheral nerve leads to pain, paresthesia, and paralysis. So these are the 5 P of the occlusion. That is acute limb ischemia resulting in pain, paralysis, absence of pulse, pallor and paresthesia. These are the 5 P. Pain, paralysis, pulse absent, then pallor, paresthesia. Paresthesia means the numbness or the different altered sensation in that region. Next, coming to the investigation, arteriography is a must and ECG for any cardiac problem. This shows the arteriography showing the embolization of the popliteal artery. Next, coming to the treatment, anticoagulant drug like heparin, then thromboembolectomy. Next, coming to the cervical drip. It is also one among the vascular disease, peripheral vascular disease. Here the subclavian artery and the brachial plexus passes through a narrow triangle termed as scalene triangle. And when the cervical rib, this cervix don't have any rib, so extra growth of a cervical rib is present. The flora of scalene triangle leading to the it will be raised leading to the compression of the subclavian artery and the brachial plexus. So this is how the you can see how the I think photo is not clear. So an extra bone growth is causing severe pain. Okay, so there will be pain and tenderness in the supraclavicular fossa, and we can see a hard and totally fixed lump in the supraclavicular fossa. That is the clinical feature. And vascular, what the symptom will be? The patient will be complaining of a pain radiating to the upper arm and numbness to the fingers, and hand become cold and pallor as the subclavian artery is affected. Then neurological, sensory, tingling, numbness, and pain along the medial side of the forearm and head. And there will be loss of power of the hand in the motor region and the wasting of the thenar and hypothenar muscles. Coming to the and that's all about the arterial diseases. Next, we will move on to aneurysm. Okay, one more topic related to that, aneurysm. So what do you mean by aneurysm? Aneurysm is the abnormal abnormal permanent dilatation of the localized segment of an arterial system. Sorry, not cyst, arterial system. So mostly it can reach up to 1.5 times larger than normal vessel diameter. Coming to the arterial walls, I think you'll be knowing the 3 layers are the tunica media, and tunica adventitia. And it can be mainly common locations are aortic, femoral, popliteal, iliac, and cerebral. So commonest is a aortic, that is 60% abdominal and 40% thoracic. Abdominal aortic aneurysm, AAA, or then thoracic aortic aneurysm and cerebral aneurysm are the most life-threatening conditions. It can be caused by atherosclerosis, infection, trauma, or arteritis. Cerebral aneurysm particularly occurs in the circle of Willis. So first classification, true aneurysm and false aneurysm. True aneurysm is again classified as, actually, true aneurysm is classified as three: saccular, fusiform, and dissecting. So these are the example how the saccular, fusiform, and ruptured aneurysm, how it will be. Then in the brain, how it will be in the circle of Willis, how the aneurysm can occur. So mainly I told causes will be atherosclerosis, chronic hypertension, genetic Marfan syndrome, Ehlers-Danlos syndrome, then acquired like in scurvy, infections like syphilis, mycotic infection, then any other traumatic. Coming to the pathophysiology. So what happens because of the etiological factors? There will be vessel wall stress, then weakening or and degeneration of the vessel wall, and there will be outpouching of the vessel vein walls, and if not treated, it will rupture. So what we have to do is the prevention of the rupture of the aneurysm. So mainly in risk factors, male it is common smoking, hypertension, hyperlipidemia, genetic disorders, and obesity can be the risk factors. Mainly, what is the complication? High mortality rate due to rupture, which results in internal bleeding or increased intracranial pressure if it is in the brain. Then compression to the surrounding tissues and causing pain. Then thrombosis, hemorrhagic stroke, subarachnoid hemorrhage, all are complications. The signs and symptoms, mostly till a rupture, it will be asymptomatic. If superficial, pulsating mass can be felt, and on rupture, severe pain in that specific location is seen, and hypotension. So diagnosis, mainly history, we have to see any injury, trauma, or surgical intervention. In ultrasound, we can see useful in monitoring the size of an aneurysm. CT angiogram. CT angiogram will be the accurate test to measure the cross-sectional diameter and presence of a thrombus in the aneurysm. Then physical examination is obviously needed to see the pulsating mass. Then ECG to rule out myocardial infarction. Differential diagnosis, like in arterial dilatation less than 50% above or normal, there is ectasia. Then arteriomegaly, like diffuse enlargement in some arterial segments which increase in diameter greater than 50% of normal expected diameter. It is called arteriomegaly. Okay. The aim of management is to prevent aneurysm from rupturing. So, conservative and surgical management, conservative risk factor modification like obesity control and all, then tight control of blood pressure, periodical monitoring of the site, then clipping of the aneurysm. Surgical clipping is to isolate an aneurysm from the normal circulation without blocking of any uh, small perforating arteries nearby. That is the clipping of the aneurysm. Then wrapping of the aneurysm. That is abnormal arterial wall is tightly and completely wrapped, including the parent artery, and cemented with a plastic adhesive. That is biological or synthetic wrap is done. Then coiling of the aneurysm. That is a catheter is used to reach the aneurysm in the brain. Mainly it is done in the brain, that is coiling. Then platinum coils are released, then coils induce clotting or embolization of the aneurysm and prevent the blood from getting into it. So that's all about aneurysm. Next, one more topic, that is gangrene. So as I already told, there's all results like in any arterial disease or any like venous ulcer or any diabetic foot ulcers, all results in gangrene. So, what is gangrene? Gangrene is a type of macroscopic death of the tissue with a superadded putrefaction, is because of the caused by ischemia or an infection, either because of the absence of oxygen or due to any infection. Mainly, it affects in the limb, intestine, or appendix, or any part like that where the blood supply is affected. So it can be etiology can be atherosclerosis, embolus formation, peripheral vascular diseases or peripheral arterial diseases, then the Reynolds disease, Burger's disease, and even in the diabetic foot ulcers. And infection, bacterial infection like Clostridium, then surgical wounds also it can result in this gangrene, then other burns, chemicals, all this can cause. So already I told Burger's disease, thromboangiitis obliterans, Raynaud's disease, all can result in gangrene formation. So some of the examples we can divide as a types: dry gangrene and wet gangrene. So in that dry gangrene, diabetic gangrene, and vascular disease gangrene can be classified as dry gangrene. Then wet gangrene, it can be either infection due to infection, either internal gangrene and gas gangrene. First of all, dry gangrene. Dry gangrene occurs due to sudden gradual loss of blood supply. So in case of diabetes and all, how it will be, because of the glucose latent tissue, oxygen supply is reduced or the blood supply is reduced in the tips. So gradual loss of blood supply will occur. And first the patient, that affected area becomes numb and become cold. Then discoloration occurs that vary from greenish or reddish to brown and eventually black. What is wet gangrene? It may be, cause may be same as dry, but always it include infection. Is due to sudden loss of blood supply, and the initial symptom of the this gangrene is will be swelling with pain. Later, it may the signs of decay may appear, and affected part is stuffed with the blood with a, which leads to infection. Toxins produced by the bacteria gets absorbed, leading to septicemia and finally death. So these are the difference between dry and wet gangrene. So dry gangrene, we can see a clear line of demarcation. In case of wet, a line of demarcation is absent. It may be like spreading very widely. Then dry, mummified will be dry gangrene. Then wet means it will be edematous, vitrified and discolored. There will be gradual and slow loss of blood supply in case of dry gangrene, and there will be sudden loss of blood supply in wet gangrene. Then separation is by an aseptic ulceration. Aseptic means no infection is there. Then septic ulceration causes separation. In case here, arterial occlusion alone is there in the dry gangrene. Wet gangrene, most commonly venous ulceration occlusion also will be there. Then causes more are atherosclerosis, diabetes, and all. In case of wet gangrene, emboli, trauma, infections are the main causes. Limited amputation is sufficient in case of dry gangrene, like in diabetes and all. Even the small finger is getting gangrene, it wants suddenly spread to the upper limb. Sorry, to the upper part of the lower limb. But so limited amputation, if we can check that spread. But here, wet gangrene, we need a higher amputation is often needed. Next, one more gangrene is a gas gangrene. It is mainly a one special form of wet gangrene caused by gas forming Clostridia, that is a gram-positive bacteria, Clostridium perfringensis. It is also known as myonecrosis, which is the necrotic damage of the to the muscle tissue. It can be observed in conditions such as surgical wound, bacterial infections, etc. Other causes are um, envenomation by the snake, ischemic necrosis by the vascular blockage. Then internal gangrene. I think already gangrene in of the appendicitis and all has a complication of appendicectomy. Appendicitis has been taught. So here a type of gangrene occurs when the blood flow to the that even in the hernia also in the strangulation stage we can see the gangrene formation. So the internal organ is blocked. The blood flow to the internal organ is blocked. In that case, we can see internal gangrene. So there will be along with the other symptoms, chills and fever, then confusion, nausea, vomiting, diarrhea, because of the electrolyte imbalance, there will be confusion stage and severe pain and low blood pressure leading to fainting. The most above mentioned symptoms may occur as a result of septic shock and other complications. One more example of gangrene is Fournier's gangrene. It is a form of necrotizing fasciitis affecting genitals, perineal and perianal regions of the body. Necrotizing fasciitis is a serious condition that quickly kills soft tissue, including muscles, nerves, and blood vessels. Some of the risk factors are diabetes, alcohol abuse, morbid obesity, and all. So this that's about the Fournier's gangrene. Then coming to the clinical features. So you know the first there will be pallor because of the blood supply is reduced. Then grayish color, then purple and brownish black. Then there will be absence of pulse in that region. Then loss of sensation, loss of function. Line of demarcation between viable and dead tissue by a band of hyperemia and hyperesthesia along with the development of a layer of granulation tissue. So this can be considered as a signs of gangrene, loss of pulsation, loss of color, loss of temperature, loss of sensation, and loss of function. Coming to the morphological, you can see the difference of different type of gangrene. Then investigation, X-ray, MRI, CT, then blood test, WBC count, sugar, HP count, then arterial Doppler, angiogram, and US abdomen to find the status of aorta. So that some test also that to test for vascular ischemia to assess the arterial sufficiency of the lower limb. Berger's angle at which the blood gets paid while racing in the lying down or supine position. Then if it is normal circulation means it now stays pink even at 90 degrees, but Berger's angle, if in case of this disease, arterial diseases, there will be severe ischemia below the angle of 20 degree. So then Allen's test to assess the arterial blood of hand, the arterial radial and the ulnar artery to detect the peripheral arterial disease. Which type of so it is the gas and gangrene is the major complicated one. Then wet gangrene, then dry. So next prognosis in gas gangrene, death can occur within 48 hours if left untreated. Dry gangrene has a better prognosis than a better wet gangrene. Mostly only 20% or 15 to 20% need amputation. Then approximately 6 to 7% of people will patient will die with this will increase to 20 to 25 if infection is spread throughout the body. Treatment through antibiotics and medical procedures to remove the unhealthy tissue. Then surgery like amputation, skin grafting, vascular surgery, and supportive care. So next topic, this is also one important heading for 5 mark question, amputation. It is a calculated surgical removal of a whole or a part of an extremity when its blood supply is irreversibly compromised by disease or severe injury. So you can see how which are the level where amputation can be done, like transpharyngeal, transmetacarpal. According to the grade of gangrene formation, we can divide that, and then hip disarticulation, transfemoral, through knee, transtibial, like that. Amputation of the foot also, toe amputation is more common. Then one two names are there. Symes amputation is a surgical removal of the foot due to serious injury or a disease. The heel pad is left for bearing weight and fitting the prosthetic foot. Sims at amputation, how it is done. So what are the principles of amputation? Proper marking of the skin incision is essential. Tourniquet should be tied and should not be removed in vascular disease. Then proximal part, there should be muscle compartment, and distal part only the skin and deep fascia. Then flap should be semicircular if adequate length. The nerve should be pulled out and pulled down and cutting with a sharp knife. The bone should be cut and all the sharp margins should be rounded. The skin is pulled down by using skin traction to have better skin coverage. Then skin flap is to be sutured. Regular dressing is done. The patient should be mobilized using axillary crutches. Oh. And after 3 months, once the scar matured and the stump is supple, the proper prosthesis is fit. Then plaster pylon is applied to the stump and a prosthetic extension is fit to facilitate partial weight bearing. Then post-operatively, active exercise should be given to proximal joint so that the prosthesis can be fit to the properly. And, prosthetic limb. Then plaster pylon, a connection between residual limb and prosthetic limb. How to improve circulation? Walking is simple and effective way to improve the circulation. Stop smoking, fluid intake, and regular massage. So these are the different type of gangrene, wet gangrene, dry gangrene, then gas gangrene, you can see ponish gangrene, then dry gangrene, one other example, then gas gangrene. Thank you. So next coming to one more topic, that is tennis elbow. Just a small topic only, I'll wind up in few minutes. So this comes in the snayu vikara. So tennis elbow, I think all will be knowing about tennis play. So when we are, what happens in tennis elbow? What is the elbow? Elbow is a complex joint allowing flexion and extension of the arm, and also rotating movements of the arms. So what are the articulations between trochlea of the humerus and olecranon process of the ulna? One articulation is that between the capitulum of the humerus and the head of the radius, then between the side of radial head and radial notch of ulna. These are the articulations. So coming to tennis elbow, it is a most common cause of pain around the elbow, usually occurs between 30 to 50 years age. Exact cause is unknown. Commonly follow a period of overactivity, which involves extension and supination of the wrist. So only while playing the tennis or while riding a bike for long hour. So most of the patient comes like that. So what happens here is tendon of the extensor carpi radialis brevis is the most commonly involved. So we'll have the tenderness in the lateral epicondyle of the humerus. So when we are feeling the lateral epicondyle condyle of the humerus, we can get the severe tenderness can be felt, and there will be forced palmar flexion and pronation against resistance, which produce pain. So we have to do the test like we have to force the palmar flexion and pronation against resistance. So in that moments, we can get the pain. The patient will complain of pain. So on examination, pain present just distal and anterior to the lateral epicondyle of the humerus. So treatment in allopathy, prognosis is good only. Many cases resolve without the need of any medical. Once that muscles are relaxed itself, it will be relieved. Analgesics may be sufficient sometimes. Then locally injection hydrocortisone is required in some cases. Physiotherapy is also useful. The tennis elbow splint, which is also designed to alter the pull of the muscle. Then surgery may be occasionally indicated, and local excision of the abnormal tissue, which produce good results in 70 to 80%. Operative procedures like aspiration, Koch's method, Langenbeck's method, and fusion is done. So that is all about. So no need of going into details. So in our case, it is we can go for Agni Karma. Okay. So, and even some Marma therapies to relax the muscles in the upper arm, we can do. That is enough for relieving the pain in the tennis elbow. And in case of varicose vein, I will share the treatment protocol we used to follow. And other thing, I think that is enough for today. Any doubt you can ask.